Without further ado, Dr. Shu, take it away.
Awesome, thank you. Let's go ahead and pull up. I'll get my talk going. And, all right, can everyone see my screen?
Yes.
All right, perfect. So thanks again for
Joe, we're seeing your presentation mode.
Seeing presentation mode, okay.
We are.
Let me do stop share. Let me do it again. Thanks for that. And then let me see if I can screen share. I'm not sure if this will do it either. There's a way I should be able to toggle over from here. Are you seeing the presentation mode or you're seeing the real thing?
Still presentation mode. I don't know if you can share the individual, like your second screen instead of the actual program, or is that what you're doing?
I think I can do it here. Hold on one second. So slideshow. How's that?
Good. You're good to go.
All right, good. A lot of clicks, a lot of clicks. It's like an EHR. So good. Thanks for having me this morning. We'll talk a little bit about some of the opioid stuff. And what we'll try to focus on this morning is to be a little bit more practical. We've bludgeoned you with data over the past few years, and I think people get it to a certain extent. But what I want to do is really help give people some tools. Some of these have already been in practice and piloted by our own group here. And so a lot of you may be familiar with it, but we just want to make sure that everyone knows the resources are available and to really give you toolkit style resources. We have a lot of disclosures around this type of work. We've been very fortunate to be funded, to be federally funded to lead some of this work for our health system and to translate that across the United States. I would like to thank Dr. Seymour and Megan Wally and Erica Grachowski, who's really helped put together some of these slides for this work. And you'll hear Erica's name a few times as she'll be a resource for you with some of the patient-facing materials. As Dr. Pat said, this is a CME requirement. North and South Carolina have different different laws around this, but basically it boils down to 1 hour a year. So this will meet your CME for the year. So I'll give you a little bit of updates on 2020. As everyone knows, this has been a little bit of a challenging year. And so we'll talk about when a pandemic and an epidemic meet. And unfortunately, due to a variety of different reasons, potentially isolation, potentially decline in mental health across the United States, we've actually been seeing some spikes. It is a little bit harder to track deaths than it is overdoses. Deaths tend to lag a little bit behind on the data as they do require some verification. And so a variety of different organizations like AAMC have put out some warnings and information for physicians as well as the AMA, because this really is becoming more and more of an issue as 2020 and the pandemic have continued. In North Carolina, again, what I said is that deaths have to be verified, and so those data on deaths tend to lag almost 2 years behind. But you can look at overdoses in the emergency department, and those have been rising tremendously in North Carolina. You can actually see that due to the pandemic, you actually had fewer ED visits as people, especially in the early phases of the pandemic in our state, really tried to avoid the ED. Except there was a significant increase, about 21% in drug-related overdoses. And of course, the majority of that increase was from opioids directly, as it pretty much always has been. South Carolina has seen a similar increase in opioid challenges associated with the pandemic as well. So how are we doing nationwide? On this? Not great, actually, it turns out. Some of the prescribing stuff has improved, but synthetic opioids have taken over, and this is where Fentanyl has really been one of the biggest drivers. Interestingly, there's been a little bit of an increase in tramadol being a player in some of this as well. So that's lumped in with synthetic opioids as well. But the majority of this is driven by synthetic fentanyl with related deaths. So maybe we need to have a little bit of good news. Again, being 2020, let's talk a little bit about some good news. One of which is that whether you think it's going to be a big impact or not, Purdue Pharma has declared bankruptcy. As many of you know, they've been shuttling funding off, hiding their money offshore for a while. But at least have pled guilty to some federal criminal charges. They've pled guilty in the past with smaller economic penalties, but hopefully these $8 billion will actually go towards treatment for some of those patients that have been brought down this pathway. Other things that we can look at that are probably good news are trends in prescribing rates. So this is 2012, and if you look, these darker colors, which I can't tell you exactly what these colors are, being colorblind myself, but these darker is bad on these types of maps. So this means that we're North and South Carolina as well as Georgia are in the close to 100 per 100 prescription rates. You've heard me talk about that, where we were writing prescriptions so that every man, woman, and child in these states could have a prescription in a single year, which didn't seem to make much sense. So that's 2012. You see 2 years later, really not much has changed by 2014. But then as the word starts to get out and some of the interventions start to get out by 2016, there's been some movement in our region with the exception of South Carolina. And then by 2018, South Carolina is still lagging behind a little bit, but improving. And so that's one of the challenges now, is that the deaths are really no longer related to prescribing. Prescribing has gotten better. And again, the goal is not to restrict opioids. The goal is to balance the appropriate use of opioids and other types of pain medication that are non-opioid related. But it's no longer, these deaths are no longer related to prescribing. So if you're on the public health side of things, like a lot of us are with this, the news is not great. If you're on the musculoskeletal outcome side, the news is actually quite good, because as many of you know, and we've covered in a variety of these talks before, is that patients that are on fewer opioids for shorter periods of time, their readmission rates, their length of stay, and their complication rates from musculoskeletal surgery is actually lower. And so our patient outcomes are probably improving because of this. And Dr. Hammond has a pretty big randomized clinical trial ongoing now in a variety of different specialties, and we hope that as those results get published, we're able to show that those patients that are in the low to no opioid pathway are doing just as well, maybe even better. So let's get on to some of the toolkit. Again, I'm very fortunate to work with this team, with Megan Wally, Dr. Seymour. We actually helped lead the clinical practice guidelines for the Orthopedic Trauma Association. And this was really the only guidelines at the time, and still is one of the better guidelines at the time for acute musculoskeletal injury. There are chronic pain guidelines from the CDC, but this is really trying to be very helpful for people that are treating acute musculoskeletal injury. Again, the concept here was to be practical, not to just give some evidence-based review and at the end of the day say we can't make a recommendation. So what we did is we used the best evidence using great criteria, but we made real recommendations. We took a stand and said these are the things that, based on the body of evidence, and evidence not being perfect, that we think are supported in the literature. We made it open access so that anyone can get it, and so you don't have to subscribe to the Journal of Orthopedic Trauma to get this. And we made it agnostic to specialty. So we talked a lot about fracture work in here as well, but it's really for anyone with an acute musculoskeletal injury. And then we also wanted to publish the methodology for a couple of reasons. Number one, we really, like I said, we went out and made real recommendations. So we want people to have the data so that they can scrutinize it appropriately scientifically. Number two, it's a tremendous resource for people moving forward as far as the references that are there. And then we also try to identify research gaps. Other parts of the philosophy, which you've heard before, are balancing safety and comfort. This is not about opiate restriction. This is about trying to have our patients be both safe and comfortable at the same time while being treated for their musculoskeletal injury, whether that involves surgery or not. And it's a true multimodal approach. A lot of times people talk about multimodal, and it's really just a cocktail of pharmaceuticals. And we're trying to really get people to move away from being pharmacocentric, which is really sort of an American philosophy, to really understanding the benefits of physical and cognitive strategies for pain management. Other things is it needs to be scalable and applicable. Scalable meaning we need to be able to treat a tremendous number of patients. And so it can't just be boutique for a small set of patients that once you top out, you're done. And also applicable. We have a very, very large health system that has a very wide footprint, and also has people of very different socioeconomic backgrounds. And so we need something that's applicable to everyone. And so again, practical, as we gave things like this that are almost like a prescription for how to taper your patients in the outpatient setting. This is what the guidelines ended up looking like. Again, it's in the Journal of Orthopedic Trauma, published last year, and we'll go through just a couple of the practical aspects that we can use as a toolkit to a certain extent. And so we'll go into the pharmaceutical stuff. We actually broke these things up into 3 categories: major musculoskeletal surgery. And so you can see we didn't put a diagnosis here. We didn't put, this type of fracture, that type of fracture. It doesn't have to be a fracture. So we looked at major musculoskeletal surgery, and there's a taper on here to really help people. And you basically can just implement this into your practice. This is what we're using in the clinics to help with people. And we did the math for you as well. I think a lot of people went to taking out the acetaminophen from some of the combined analgesics and giving that separately as scheduled, and then giving a non-combined opioid. The challenge with that is the non-combined opioid actually has a tremendous street value and actually can be used separately to a certain extent. And you really take out the benefit of the combined analgesic. So we chose to keep it in and just do the math for you so that it's safe for acetaminophen toxicity. And then also you can see we have a category of minor musculoskeletal injury that has a similar taper that starts with lower doses. These are all 4-week tapers to get people completely off opiates by 4 weeks. And then there's a non-operative pathway as well that can involve a much shorter course of an opiate. Other patient-facing material, and again, Erica really helped me pull together some of the stuff for this, is we have a prescribing policy here. It's really more of an acute pain education. Erica brought that out. And what it does actually talks directly to the patient and gives them some education around the why. A lot of times we just give patients the how and the what. This really kind of gives them the why. And so really becomes a real resource for acute pain education. And there are copies of this, and if Erica chooses, she can potentially put her email in the chat. We've run most of this stuff through the education committee here, and so these are patient-facing materials that have been changed so that they're appropriate for giving directly to the patients. So we'll go through some of the physical things. Shout out to Jenna Garofalo, who put together a lot of these handouts that we piloted in my clinic, and now they're available. And you can see it says Musculoskeletal Institute at the top. And these are things that actually are good patient resources, because a lot of times we tell people, get this, get that, do some bags of ice. And it gives patients a variety of treatment options depending on their income. Some of these, like this one at the top, and I have no financial relationships with any of these companies. The one at the top on this patient's back is actually, that has a whole line that are very inexpensive. Getting up to some of these things like the fancy wraps and things for shoulders, it become a little bit more expensive. And then some of the cryotherapy machines that can be a little bit more expensive even. But those can also potentially be rented or bought as a used device. Why do we push cryotherapy? There have been a variety of different studies of variable effect size that show that they can kind of give you the double whammy. They decrease pain and decrease opiate use at the same time. And so that's why a lot of us are so enthusiastic about it, so much so that a lot of us are putting this on in the operating room and it doesn't have to be a cryotherapy device or a cuff or anything like that. It can just be bags of ice in a pillowcase. So we're putting large Ziploc bags of ice in a pillowcase and wrapping it around the patient's limb. These are some of the websites that where you can find some of these products, and I'll often just direct my patients to these products so they can pick whatever they want. And a lot of these, like this bottom website, they'll help you through the process of using your flexible spending account or health savings account for those people who have an FSA or an HSA to purchase these devices. Compression, believe it or not, actually has some reasonable, it's not high level data, but lower level data that it can actually help. And for those of you who've had a condition an injury that's resulted in edema or swelling, you know that it can actually contribute to the pain. And so there are a variety of different ways that this can be done. These are some of the patient facing words that are in our compression handout that can be made available to you as well. And these are some of the products that are available online. There are one of the challenges with compression, and there are really nice medical compression garments that people can get, and you write a prescription for them. And we still write a prescription for these so that people can claim them on their insurance. One of the barriers is that people don't like the way they look. Honestly, they just don't like the way the standard compression garments look, and because they're solid and they're one or two colors. And so you can actually go online and find fairly cost-effective alternatives that actually look reasonable with your work clothes. Thanks to Dr. Shing for helping develop our patient-facing TENS handout. So we talked a fair amount about TENS around here now. The way that TENS works, it works by gate control theory, so it outcompetes the pain signal, and so down regulates it as well. So it not only outcompetes it through larger peripheral nerve fibers, but has a down regulatory function as well. And so the way I describe it to people rather than tell them about gate control theory is that it helps block the pain. It doesn't make you numb, but it helps block the pain to a certain extent. And these TENS units, patients can get them online. They're actually relatively inexpensive to purchase if they want to purchase them on themselves, but they're actually also available in most of our facilities at Mercy, Maine, One Day Surgery have these available for placement on the patient if you want. And we've pre-positioned handouts like this at most of the, I think all of the places have pre-positioned handouts. Sometimes the recovery room nurses have a little bit of a hard time finding it, but they are available, and they're available in electronic format as well to give to the patients to help teach them how to use these units that are relatively easy to use, just 2 or 3 steps. And so this is how I like to send patients out of the operating room with ice. We didn't have the Ziplocs that day. That's a cassette case, which is a little bit non-ideal. It's probably too heavy. But there's a tibial plateau fracture that wakes up in the PACU, also having aromatherapy in the PACU as well as ice. And you see the TENS units leads coming out the top. One of the tips that I learned from actually an ICU nurse is if you take the solidifier that they normally pour in the irrigation at the end of the case, and you put that into the bags of ice, it actually, when the ice melts, it just becomes like a custom gel ice pack instead of running all over that was one of the challenges, and one of the barriers to the use of ice initially is that once it starts to leak, it leaks all over your post-op dressing. And so if you put solidifier in the bag, it prevents that problem. We'll talk a little bit about some of the cognitive strategies. We'll try and move through this to give time for the next talk. There are a variety of different cognitive strategies. As you know, this is one of the biggest challenges for some of our patients. And it's one of the hardest ones for patients to accept. There's lots of data that web-based therapies and things are very, very effective. But a lot of times, I think what the patients have been more open to using are things like the Calm app or the Headspace app. These are free free apps you can get on your cell phone that really help you through guided imagery. This is what the Headspace app looks like. It's the one that I use. The Calm app was recently endorsed by LeBron James. And so I think that people are really starting to become aware that these things are not only available, but real people are using them. There are other different websites that are available for things like self-healing meditation. And these are, again, these are free. These are on YouTube. These links are active. And so we can send around this talk for people as well, and you can click on the links and watch a lot of these things. But one of the things I tell the patients as well is not everything is tailored for each individual. And so if you just want to go on YouTube and you search and use the search term guided meditation, you'll have a variety of different things that you can do. These are really nice relaxation strategies, anywhere from having a simple guided meditation like the one on the beach to actually having really more of a almost a didactic type of a lesson. This link on YouTube is something that's probably worth looking at. Downside is about 4 minutes, which might be beyond a lot of people's attention span now, but it's actually really quite good. It's designed to be patient facing, and it really explains to them the difference between pain and nociception, and what to expect after a musculoskeletal injury or surgery. David Ring gave this resource to me, and I've given it to a variety of different patients, and I think it's really one of the best ones that I've seen out there that's really specific for musculoskeletal care. So let's talk a little bit about what we have been doing here locally in the time that we have left. What we've tried to do is integrate real information in real time in an easy way to make your lives more efficient, but still have the information you need to appropriately prescribe to patients. So identifying those high-risk patients and bringing that information to you in real time, and then also implementing some of the things that we just talked about in the guidelines, and actually bring them into clinical care. And so we'll actually do this backwards, because Improve came later after Primum, but implementing some of this stuff for those of us on the front lines of musculoskeletal care. This is something that you should be aware of and make sure that you have at your fingertips, because it can be very helpful. And so part of the Improve work that we're doing that's very practical, that's part of what we're talking about, this toolkit philosophy, is the adult opioid sparing pain management order set. So this is available. It's all throughout our inpatient record now. And what happens with this, what's great, is you don't have to remember all these things. So aromatherapy, TENS, ice packs, telling the patient to do music therapy or listen to Pandora on the Get Well network. Those are all pre-checked. So they're pre-checked, so you don't even have to think about it. It's already on there for you, so that you're doing a true multimodal pain management just by launching this order set. And this order set was built with CDC funding for us. There still are the medication strategies that you'd want to see, and these are the non-opioid strategies that are pre-checked for you, so that they can have scheduled medications that'll still be in compliance with toxicity levels with your other medications like these, your opioid options. One of the things that I'll highlight on these opioid options, and one of the things that we really took care to make sure that we did, is to prescribe with precision. So these ranges that we've been talking about for the past few years of 1 to 2 every 4 to 6 hours, we want this all to go away, because this really gives the nurse or the patient the ability to triple the dose of a medication for a patient, which seems a little bit, to me, it seems unusual. There's no other medication that we'd allow for tripling of the dose. And so you can see, if you take a hydrocodone pill 1 every 6 hours, you're taking 4 pills a day. But that's within that same range, you can triple the dose to 12 pills a day if you're taking 2 every 4 hours. So that just doesn't make much sense, that we're expecting to not have a toxicity when we're having these broad ranges. And so you can see in these any of these opioids that are in our adult opioid sparing pain management order set, that those are they're not ranges for either the dose or the duration. So a lot of talk that you'll hear on the media is, the solution to the opioid epidemic is cannabis, and it's gotten a lot of attention. And so we wanted to at least bring that up now and give you some tools around that. One of the tools is just published ahead of print. And so we'll be available soon. We can even send you one of the copies of it that aren't published yet. So we hope that this will be a tool for you. Thanks to Stuart Buck for helping lead this work. And these next few slides are from his grand rounds that he gave several years ago, which really became the background of this cannabis review that's very specific for musculoskeletal. And so just real quickly, cannabis is made primarily of two components. I mean, there's a variety of different things, but the primarily active ingredients are THC, which is the, it's the euphoric type thing, it's the hook, and then CBD, which we think has a lot of the, it's not psychoactive, but has a lot of the potentially positive benefits that people seem to hang their hat on. The real challenge is that hanging your hat on CBD, when you talk to cannabis, the THC to CBD ratio is completely different now, and actually the strains have been modified to really increase the THC because it's the hook, right? And so, and this concept that that cannabis is not addictive is not supported in the literature, and so that's sort of a news media type of a thing that is not supported by scientific literature. And so this is the situation with the THC content increasing while CBD levels remain relatively constant in this. And you say, well, does it work for pain? When compared against placebo, just like most other things that we do when compared against placebo, it actually tends to work with either moderate or low quality data compared to placebo. But you could put tricyclic antidepressants in there, you could put NSAIDs in there, you could put Tylenol in there, you could put an opiate in there, and compared to placebo, those are effective with low to moderate effect sizes and low to moderate strengths. If you look at evidence-based reviews like this one, this Cochrane database review, they looked specifically at neuropathic pain. They did have some pain relief compared again to placebo, but significantly more adverse events and incidents of psychiatric disorders. So again, more on pain. It did improve visual analog scale again compared to placebo, but there also is this feeling of high and being impaired. At the higher doses, this impairment not only involved attention and learning, but also involved intentional learning and memory, but it also involved psychomotor speed. So actually had physical effects at the higher doses of THC. And this concept that cannabis is going to be a solution to the opioid epidemic, again, is not really supported very well in the literature. In fact, medical cannabis use seems to be associated with increased opiate use or even misuse among those people that are chronic opiate users, so already on a stable dose. And so again, another more data that it probably is not the solution for the opioid epidemic, but definitely warrants further research. And hopefully we're making decisions around cannabis in an evidence-based way, rather than the way we got into some of these other areas, really driven by emotion, media, and big industry. Because if you think cannabis is small industry, is a multi-billion-dollar industry in this country. So again, this is the reference that was recently published. And let's flip back to opioids here for a little bit and then talk about some of our results. So again, we implemented the pathway here with both Primum and Improve. We do have some data on Primum, as Improve is in the process now and relatively new. And the way that Primum works is we identified 5 evidence-based risk factors for opiate misuse, abuse, or diversion. But a lot of these are buried down into the electronic health record. And so what we wanted to do is, when you're prescribing a medication, to give those to you. And again, it's only in the middle of the prescription. So it's only if you're doing an opiate prescription, give that information, and with one button be able to cancel or continue, to really make it an optimal and user-friendly. Now, as ideology, there are different barriers that we could have put into place to make it cleaner from a research perspective, but we wanted to optimize a user-friendly intervention so that people would use it over time and not develop alert fatigue. We also want to be product forward as part of our ideology, and so we've rolled out a variety of publications, even while the bigger intervention data was being collected, because I think having the responsibility in this domain, being federally funded, we wanted to put out information that was good information to help guide care, both within our various divisions and across the United States. So some of the local impacts, just in the first 3 years, there were about 43,000 high-risk prescriptions that were prevented from this. So again, the main goal is not prevention. The main goal is to give information, have influence. And it turns out that close to 1 in 4 of our patients have some risk factors. And so these, the clinical decision support interventions kind of launched slowly over time. They didn't all launch at once. And so it required a tremendous amount of mathematical modeling to sort out some of these data. But basically close to a quarter of encounters that had an opioid prescription or a benzodiazepine prescription triggered an alert. And we influenced the prescriber influence really almost 20% of the time. And so really a tremendous number. And again, the goal is not to discontinue anything. The goal is to influence it. And you say, well, you know, our satisfaction scores plummeting because y'all are meddling with our opioid prescriptions and trying to guide us with our opioid prescriptions. And so we looked at that as well. We looked at patient satisfaction scores, and even some of the comments, because one of the pushback we got is that people are going to just be crushing my Prescribing scores and writing all these negative comments about me. And of over 7,000 comments, 10 were related to opioids. And so that's 0.1%. And so I can't say it's 0, it's 10. It's not 0, it's 10. And so people can say those things, but it didn't seem to have an impact across different practice types and different prescribing. Some of the other alerts that we implemented that were based on the CDC guidelines, we were able to influence the initiation of pain agreements and prescribing naloxone. And hopefully just the discussion around naloxone, which we can't capture with data, has actually helped our prescribers when they do a high MME prescription, and it gives them an alert that they need to prescribe naloxone, and maybe even influences their prescription, but also generates a discussion with the family around those medications. As the number of risk factors increase, the likelihood of the decision being influenced increase, which actually makes sense. And so to me, when I look at these data, I say, look, that means that prescribers are reacting appropriately. They get information that the patient's high risk, and they're reacting appropriately. This is our how the decisions were influenced over time was relatively stable. It's very interesting that in this region, where we actually had a bump in influence of prescribing, there was no new intervention that was launched at that time. But in those 2017 timeframes, I think that things were very, very high in the media on a lot of this work, and then we were able to return to baseline. And so what this graph shows is if you had alert fatigue, you would see a downtrending graph over time. And so this is over a tremendous period of time, and the response rates and influence rates from the alert are relatively stable over many, many years, which really demonstrates a sustained influence. And so we had influence over about 1 in 5 encounters that involved a prescription opiate or benzodiazepine, and that intervention was sustained with minimal prescriber fatigue over 42 months. So we thought that was a pretty tremendous in such a large health system with a wide variety of prescribers. So hopefully today we've given you a variety of different things that you can take home and implement into your practice today, tomorrow, and again, for any of these patient-facing materials, and we're happy to get those to you. And the order set that I talked about in here is already available right now. So hopefully that helps give you things that you can implement right away to improve health, elevate hope, and advance healing for all. Thank you.
Excellent. Thanks, Joe. Appreciate all the tools you provided us. I was busy texting my PP to make sure we get some of those tools in our own clinic here. So thanks for that. We do have time for a couple of comments or questions for Dr. Hsu before we hear from Dr. Ko. If anybody has any burning questions. Obviously, also in the chat, Erica put her email in there if you want to contact her for any of the information. Or obviously, Joe's always happy for people to reach out to him.
Hey, Joe, it's Natty.
Hey, man.
That was a great update. Thank you. Are you able to follow the success of the opioid sparing pathway in regards to, I guess you could use the word failure, or your patients having to receive more than the order set initially gave them? And I guess the secondary question would be, are you still finding the biggest barrier is provider buy-in? And are you seeing any other barriers other than that as you launch Improve?
Yeah, I would love to say that yes, we very smoothly have all the data with Improve. That was the concept, is that it would gather data like Premium did in real time. We had some hiccups with the data initially. We think we solved a lot of those problems, but yes, we'll be able to get the actual dose duration of all the medications that the patient gets, both in their inpatient stay and a discharge. The nice thing too is that with Premium still live, we're able to follow those patients through their entire course of care, and so we'll even get their outpatient prescriptions within our health system. And then your second question is actually the toughest one, as you know. It's just getting buy-in. We piloted this order set for a really long time. We got input from all kinds of different services and specialties, and even some of the people who gave input on the order set have not really implemented it. So buy-in is a little bit of a challenge. The good news is I think that most of our residents and fellows have used the order set extensively, and you know, we can talk about how to implement change and process change, but often the diffusion of having our learners go out and work with different surgeons and different settings has actually probably proliferated the use of the data set more than anything. We get a weekly report on who's using the data set. So every Monday, Dr. Seymour, myself, and Megan Wally click on the report to see who's used it from the week before.
Great, thank you.
Excellent.